Hello. This presentation was created by Dr. Donald Juravich, a professor of geriatrics at the University of North Dakota. Today, this presentation is on transitions of care. This is a topic brought by the Dakota Geriatrics Program, which is a HRSA-funded geriatric workforce enhancement program. Here we see Frederick Remington's painting of a cowboy who is coming down a mountain on his horse, and it doesn't look too steady. This is very similar to transitions of care, where we often are navigating a rocky and treacherous trail. Our objectives are to look at why care transitions are frequently suboptimal. We want to look at the vulnerability of older adults during these transitions and consider what the risk factors are for experiencing an unsafe transition, as well as how we might be able to improve transitional care. This painting by Winslow Homer is of a sailor shipwrecked with sharks circling around. There was great concern about this painting originally because Winslow Homer did not include the distant ship that you can see in the left upper background. There's just a shadow of a ship because without that ship, there was really a sense of no hope for the sailor ever being rescued. Later, Winslow Homer modified his painting to include that ship so that there might be an expression of hope. It seems that our transitions of care oftentimes are full of difficulties and bad outcomes, but there's hope as we look towards quality improvement in evidence-based medicine that can help in these transitions of care for this medically complex population. Notice this scenario. We have a 70-year-old diabetic man being discharged after a hospital stay for an open draining wound and possible osteomyelitis. You can see his inflammatory markers are quite elevated. He has activity of daily living deficits that includes assistance for bathing and transfer. He's required to have antibiotics for at least 6 weeks and wound care. He lives alone and does not have friends or family who live close by, and he reports that he wants to go home. What is the next course of action? A. Order home health. B. Consult psychiatry. C. Assess his decisional-making capacity. Or D. Contact a social worker for nursing home transfer. The correct answer is C. Assessing decisional-making capacity. All primary care providers should have the ability to assess decision-making capacity and don't necessarily have to refer to psychiatry or psychology to help make that determination. Which of the following is the most appropriate location for discharge for this patient? A. Acute rehabilitation unit. B. Skilled nursing facility. C. Home with home care. Or D. Continued inpatient stay. The correct answer is B. Skilled nursing facility. This individual meets all the criterion for Medicare for transfer to skilled nursing facility. He likely had 3 overnight stays at the hospital, and he had need for intravenous antibiotics, as well as intensive wound care therapy. The topics covered today are going to be risks of poor care transitions. What are the incentives and responsibilities for making a good care transition? Also, look at strategies and models that have been tested for improving that transition, and look at the different venues with which older adults are transferred. We also want to hone in on medication regimens, as well as the communication plans and overall steps to improve care transitions. We'll also touch on emerging technologies like wearable devices and AI platforms that help track recovery and medication adherence, as well as new caregiver support models that improve outcomes during transitions. Many times, transitions of care are well-intended, but they always end up having some defaults and glitches in the process. As we talk about handoffs and transfers, these can be considered within the hospital setting. For example, geriatric units at a university hospital would often have transfers from surgical services. The transfers can also occur across different healthcare settings. This typically would be from the hospital to, for instance, home healthcare could be to a long-term acute care or other settings, including hospice care. One of the most promising developments is the Guide model from CMS, which supports dementia care transitions through coordinated services and caregiver training. This aligns with broader efforts to strengthen aging-in-place infrastructure. This demonstrates the complexity that we're dealing with. You can see in the lower left-hand corner here the big H, or the hospital, and you have the patient and their caregivers all interacting at different points in time, with firstly perhaps the emergency room, maybe into the intensive care unit, hopefully not more, likely a med-surg unit, which might include in some instances an ACE unit, which is an acute care for elderly unit. This has demonstrated much better outcomes than the traditional med-surg unit as we know it. There's an inpatient rehab, outpatient rehab, certainly different levels of primary care, up in the left-hand corner. Also, issues related to transportation, medication, pharmacy, and long-term care, whether it be skilled nursing care or intermediate care, and so forth. You can see all these possible combinations can really play an important role as an individual transitions from one setting to another, particularly one that was precipitated by hospitalization and acute illness. Sometimes, there are opportunities for home care to seg to a long-term care setting, such as respite care, when the family or caregiver wants to go away for a period. They may have a week's worth of respite care and a long-term care setting as an example. Transitional care is something that can be a problem. In geriatrics, we often say that for each day in bed, there's 3 days of recovery that accumulate, unlike younger individuals where they may have an acute illness, but they recover in a very short period. 15% of older adult individuals with no activity of daily living deficit prior to hospitalization will then, because of hospitalization, acquire an ADL deficit. Of those patients with one or more ADL deficits prior to hospitalization, 45% will acquire a new and permanent ADL deficit. If you go into the hospital with one ADL problem, you're going to leave the hospital with an additional problem, and it's most likely to be a permanent part of that spiraling downward cascade of functional impairment. Importantly, there is a 3 to possibly 6-month recovery window for returning to your prior or pre-hospitalization functional status, but after that there usually is no additional recovery. Telehealth and AI tools now allow for real-time monitoring of patients post-discharge, helping identify early signs of deterioration and reducing unnecessary readmissions. These tools are especially useful during the critical recovery window. These transitions from the hospital are common and they're complicated. We have 40% of older adults experiencing more than 2 transitions within 30 days of hospital discharge that might be exemplified by transfer to nursing home, then to emergency room, and then back to the hospital or nursing home, back to the emergency room, and then back to the nursing home as an example. There's what some folks call post-hospital syndrome, which is an acquired and hopefully transient condition of vulnerability. This is associated with multiple health adversities. It's all during this process of acute illness recovery, which has different trajectories for different folks. And we've seen this in the pandemic, where some individuals, regardless of age, have post-COVID syndrome with long recovery periods for symptoms that are variable. Most of them are associated with chronic fatigue syndrome, for example. Recent studies have expanded our understanding of post-hospital syndrome, emphasizing the need for digital support tools that can help mitigate vulnerability and improve recovery trajectories. About 1 out of 5 Medicare beneficiaries will experience care transitions of some kind. Here you can see the 50-50 split of those who do have some sort of transitions. Half of these individuals will go home, the other half may end up in skilled nursing facilities, which then again is split into another 50-50 distribution, where half of those individuals will go back home after short-term stays, and the other half end up becoming permanent residents in long-term care. These suboptimal transitions cost a lot. A little under 20% of the population will end up getting re-hospitalized after their first hospitalization, and that will occur within the first 30 days of their hospital discharge. Remarkably, this number goes up if you look at a 90-day span of time. 1/3 of all these older adults end up back in the hospital. You can imagine from Medicare's point of view, spending $15 billion a year probably is not such a good price tag for dealing with all these rehospitalizations. And while there's penalties that accrue to hospitals for going over the national average in rehospitalization rates within the first 30 days, it's likely that Medicare will change that into a 90-day period, and then will put the burden on healthcare systems to find ways to keep people out of the hospital over a longer period of time. Medicare has introduced new policies, including a $2,000 cap on Part D out-of-pocket costs and expanded billing codes for transitional care management. These changes aim to reduce financial strain and incentivize better care coordination. Here's our first polling question for this topic. According to the presentation, what percentage of Medicare beneficiaries experience some form of care transition? A. 10%. B. 22%. C. 40%. Or D. 50%. The correct answer is B. 22%. One of the other suboptimal transitions relates to safety. In transitions of care, it's always the points of transition that are the most vulnerable times that we need to think about. Also, how does the information get conveyed? There might be a delay in diagnosis. Why would that be? Older adults more commonly present with atypical presentations of common issues, such as having abdominal pain, while they may have pneumonia, and so you get steered down the wrong pathway, chasing something that may turn out to be not the correct diagnosis. There's a lot of duplication of medical services. There have been many occasions where older adults get multiple head CT scans for mental status changes, and it's just duplicative and uninformative. The hospital readmissions speak for themselves, and these all create a dissatisfaction both amongst providers, patients, and their family members.